Welcome to the Community Clinical Care Podcast, broadcast from Shropshire in the UK. Welcome, and in this episode we're going to be talking about the long lie. Now, this is a problem which is occurring across the country and is anecdotally getting a little bit worse for patients due to problems with the ambulance service and times of attendance. We're now seeing our community response teams dealing with patients who are still on the floor, whereas perhaps in the past we may have dealt with patients who'd already been lifted. So this episode we're going to take a look at particularly one piece of research by Kubica, a systematic review of the literature surrounding long lies and what it can mean for our practice and our takeaways for community care. So, first thing to discuss is that there is no definition of the term long lie which is standardised at all. Kubica looked at lots of different studies and found that some people were determining a length of time on the floor as 5 minutes up to several hours, with a general consensus, although not evidence-based, around 1 hour becoming the time regarded as a long lie. But it's really interesting that some studies consider that a patient who is unable to get up quickly is a long lie as well. So that's really important, isn't it? That we need to sort of standardize our terminology or avoid using the term long lie, perhaps, when we're discussing these patients, because it may mean something to one person that means something different to another person. So let's consider, when we're writing our notes, to put a time and a context on that person's experience of being on the floor, rather than just saying a long lie. There are some aspects for us to consider about the nature of the cause of someone falling over, and also the nature of the symptoms that might have occurred because of the fall. So one thing we need to consider is that it's been found that the length of time on the floor is often badly reported. The patients themselves may not have an accurate time frame for time on the floor, and it's also being misreported by carers and families who attend. So if we were to make a judgment whether or not something is a long lie based on an arbitrary number like 1 hour, it may well be influenced by incorrect information from the patient or from their carers. So it may be a little bit of a dangerous game there, and perhaps we'd be better off considering a lie as the symptoms that may be experienced by the patient. There's a general non-evidential consideration, like I said, that there's 1 hour immobile on the floor is the time where we're going to start seeing some significant symptoms. And these are the ones we tend to think about as crush injuries. So immobility is an interesting concept, isn't it? If you delve deeper into the research, again, this is a very grey area. Does it mean stock still not moving? Or does it mean someone who's unable to move themselves sufficiently to relieve pressure damage? Arguably, there's a very great difference between a patient who's been on the floor, not able to move very much, so they're developing those constant pressure areas, and a patient who's been on the floor who is able to move. In my own practice, I've attended lots of patients who have been on the floor but able to move and get pillows under themselves, shuffle around, rebalance, reposition, so that they're not going to develop any kind of pressure sores. And these patients are generally doing very well. But that tends to be the patients with better strength and less illness in the first place. So our more frail cohort of patients, or those who are suffering from an illness that's caused them to fall over, perhaps, those we may well see with greater degrees of immobility and therefore potentially greater risk from pressure damage. However, some studies say that pressure damage can occur much quicker in patients in some circumstances. It's all well and good for a patient lying flat on the floor. They have bony prominences. So that pressure between a bony prominence, or let's say the pelvis, the shoulder or the knee perhaps, crushing a little bit of flesh between there and the floor. But what if your patient is up against a piece of furniture, or perhaps the corner of a hearth, or perhaps a door frame? That's going to create a pressure point much quicker in some circumstances, isn't it? So environmental considerations are really important to factor into the picture. The time on the floor may well be giving us one picture, but the fact that we're pressed up against something solid may well give us an entirely different clinical context. Those patients, I said, who were shuffling around on the floor, were they shuffling around because they were up against something painful? Perhaps they had no choice but to try and shuffle around because they were experiencing a pressure point. Again, that's a different clinical picture, isn't it? Any long lie is a symptom of multiple factors. So Kubica breaks it down and tells us that it's going to be physical factors, social factors, and environmental factors. And if you think about it, it makes perfect sense. People don't fall over for no reason. Perhaps the reason they've fallen over is general weakness and general frailty. Perhaps it's degeneration of the knees or degeneration of strength. But we need to work out whether or not that's an acute or a chronic problem or an exacerbation. Perhaps it's a combination of the two factors. But then why were they on the floor for a long time? That brings into itself social questions. Why did nobody assist them, pick them up, put a cushion underneath them? Are we going to see this worse in some cohorts of patients, those who live alone? We know that people who suffer from a long lie generally tend to be worse if they're female. Why is that? Perhaps don't really know. The evidence doesn't point to any conclusions on that. We also need to factor in environmental factors. So are there any factors of where the patient's living that caused the fall in the first place? It could be badly fitting shoes or rugs or poor furniture or the wrong kind of equipment, frames or sticks. It could be the patient's layout of their living space. It could be hoarding. All these different factors, they all add up to a bigger clinical picture. And they define the risk of this patient re-falling and re-experiencing harm in the future. As part of any falls response, we need to think about falls prevention as well. Really, really important that this patient's not going to re-enter the cycle once we've done these steps to try and relieve any discomfort right now. So, as we ascertained that a long lie is more than just the fact that you might be on the floor, let's have a think about those physiological issues we may well see as both a cause or an effect or both of having had a fall and laying on the floor for a while. Okay. Firstly, let's discuss hypothermia. This is generally going to be as an effect of a fall, isn't it? So let's say someone's fallen to the floor. The floor is generally cooler than it is up high because heat rises, so it may be subject to drafts. The patient may not have a duvet or a sheet over them. They may be poorly dressed if it's the night and they were in bedclothes and trying to go to the toilet, for example. Or they may well be wet. It might be their own bodily fluids. It may well be a drink that's spilt on them. All these factors may well reduce core body temperature, and with that comes its own set of physiological problems to consider. In very simple terms, we know that someone with hypothermia's organs are not going to perfuse as well. They're not going to function as well. We're not going to carry oxygen as well. It's one of those things that sort of snowballs as well. But what are we going to do about hypothermia? It's a very risky state, as we can see reflected on the News 2 scale. Hypothermia is generally thought of to be more risky than hyperthermia. What are we going to do to rewarm a patient, though? In community care medicine, we don't really have a way to rewarm a patient, so we're going to have to think outside the box and use the patient's environment for them. Drying them, redressing them, giving them blankets, that's all a very good way of stopping more heat loss, but it doesn't reheat them. We're going to have to think about things like warming hot water bottles, not hot but warm, warming drinks if they can tolerate it, a bit of food to get them firing up internally, and then putting the heating on and keeping them hot. It might be that hypothermia is the trigger that you need to consider for an acute pathway. It might be that this person can only be rewarmed in a hospital. If that's the case, then so be it. But hypothermia, definitely one to look out for as a potential red flag. Let's talk about infection for a second. So infection and deterioration or physical deterioration because of it might well be the reason for the fall in the first place. I'm sure a lot of our listeners will be familiar with the fact that someone with a urine infection or a chest infection can go off legs. It's a terrible thing to say. It's not a clinical diagnosis, is it? But actually, it means something to people. It means something to carers and generally patients. If someone could stand up okay yesterday or a couple of days ago, but today they're having trouble, that is off legs. But we need to get to the root cause of that. And perhaps our initial assessment and our A, B, C, D, E, our News 2 score is enough to justify us taking the clinical course of action, considering maybe bloods, considering maybe escalation to acute for the infection. It also prompts a clinical discovery, doesn't it? That medical model of asking the questions, getting the right picture of the patient and coming up with some differential diagnoses to present to the next step of clinical care, whether that be the GP or if you have top cover in place, your MDT. Of course, infection may also be a secondary problem from a fall. Someone experiencing a wound, for example, may well get a skin infection. This is something we perhaps will have to follow up. We know that skin infections can become very serious in some people and lead to ongoing problems and morbidity in some cases, can't it? So there's a cause and also a symptom from falls. Next, let's think about dehydration. So a patient who's been on the floor for an extended length of time, have they been able to get hold of a drink and have they drunk enough? So someone lying on the floor may be inclined not to drink because they don't want to have to go to the toilet. In my own practice, I see that quite often. Carers seem to be getting a bit more on board now with keeping fluids on, and we know the importance of fluid and keeping that kidney function up, especially if someone's going to get that derangement of their U's and E's and also potentially that rhabdomyolysis, that breakdown from pressure. We need good kidney function in order to help us get over those things. So making sure your patient's got those access to those drinks, had them, and they are processing still, really very important clinically, isn't it? Let's think about wounds. I've already talked about skin wounds. What about bigger wounds? What about those injuries, those underlying injuries as well that are going to restrict mobility or restrict mobility by pain? Someone's not going to want to move the area of the body with a wound on it, are they? Or perhaps they've hurt their ankle or their wrist. We're going to have to build a kind of clinical context around that and some safety netting. Perhaps their treatment pathway may be community care. Perhaps it may be minor injuries unit. Sometimes it's going to have to be acute. But again, that's not all factored into your News 2, is it? That doesn't always show up injuries and wounds. So that A, B, C, D, E, and especially the E to expose those wounds. We're going to have a really good look at skin for pressure damage, for skin tears, for bruising, for any kind of lacerations or abrasions. You're going to have a really good look with patient consent, of course. Bear in mind that someone that's been on the floor and that crushing or damage to those body tissues is going to have some sort of derangement to their U's and E's, in particular perhaps their potassium. So we know that just clinical care such as putting on a tourniquet for too long can raise the potassium results in blood tests. If you magnify that through something having been on the floor and getting some kind of crush injury, we're very likely to see derangement of potassium just from that localized damage. And that brings us on nicely to that last one, rhabdomyolysis. So this is the breakdown of muscle fibers that's going to then release that myoglobin, and with that comes CK or creatine kinase. We know that creatine kinase will rise gently over a period of up to about 72 hours after a crush injury. And this is a really important point to consider, that if perhaps we were to go to everyone who's on the floor, pick them up and immediately take bloods, we may well miss the fact that they've had this crush injury just looking at their bloods. The creatine kinase may well not be high until day 1, 24 hours later, or day 2, or day 3, even 72 hours later, at which point it's always worth considering whether or not long live bloods are justified at that point. In my own practice, the easiest way to justify if long live bloods are appropriate is whether or not there's been any clinical deterioration. So we're going to have to review these patients at 24, perhaps 48, definitely 72 hours post-injury to make sure there's been no clinical deterioration. The enormous red flags we're going to look out for rhabdomyolysis will be that dark coffee-coloured, brown colour or dark red coloured urine, abdominal pains, cramping, muscle pains, weakness, and then systemic issues like tachycardia, confusion or AVPU changes, that fever you might get in advanced cases. Anything like that, definitely a red flag, definitely going to have to consider acute pathways at that point. Or if the patient's resistant or has a care plan in place, then your community care is going to have to step up a notch. Point of care testing perhaps, or immediate bloods, getting those that reviewed urgently, getting some top cover in place and making sure we're going to treat that rhabdomyolysis as effectively as possible in the community. Your local pathway may dictate what that is. It may not. It might have to be a clinical conversation between yourself and a GP or overseeing clinician at that point. Okay. What I would suggest is that your 24-hour review is a chance for a second set of eyes on. So eyes on to the clinical context of what happened. So someone who wasn't there at the time, who's not got that investment, that impassioned investment, have an eyes on objectively, take a look at the news too, take a look at the context and make sure the decisions being made are correct for that patient. We're going to re-review our patient, and then perhaps at day 3 is a really good opportunity to check whether or not our day 1 strategy to monitor and or escalate is working. Day 3 might be the point where we go, do you know what, we've seen a little bit of deterioration here, our obs aren't quite as good, our patient presentation's not quite as good, something's not quite as it should be. Perhaps now's the time to consider those bloods again, maybe consider stepping up care, transferring them to hospital at home or virtual ward, or perhaps even acute, or at very least making your top cover or your GP aware of what's going on. So long lies and their treatment are very much on understanding the situation, understanding the context, and understanding that a treatment pathway is not a one-size-fits-all for our patients. We need to customize our treatment by adapting the patient's observations, keeping a very close eye on whether or not our interpretation and our treatment plan for that patient is working. It should be a fluid treatment plan. It should be not set in stone in any way. So if a patient is manifesting deterioration or some kind of problem, it can be changed. And this is the kind of patient we're going to need to keep a really close eye on. So whether or not you're still on shift or you change shift and done your handover, your clinical notes, your clinical handover is going to have to be absolutely top notch for our patients who have had a long lie, defined however you feel. So I hope you have taken away something for your own practice from this episode. On screen, if you're looking at this visually, is a link to Kubica. It's Kubica 2023. If you search that and for long lie, you will find the evidence there. And obviously their systematic review was very comprehensive, and it links to all the other potentially useful reviews and academia which might be useful for your practice. Thanks very much for joining us. Welcome to the Community Clinical Care podcast, broadcast from Shropshire in the UK.